Hello, my name is Ari Naaman. I am the president of the Autistic Self-Advocacy Network, but today I'm here in my capacity as a member of the National Council on Disability, which is an independent federal agency that advises Congress and the President on issues relating to disability policy. The National Council on Disability has 15 members. We do a wide variety of work relating to disability policy. As of late, we've been doing a considerable amount of work with respect to the Medicaid program. The Medicaid program plays a crucial role in the lives of people with disabilities. The majority of service provision delivered to people with disabilities is financed through the Medicaid program, both with respect to acute care, healthcare services, and long-term services and supports, which, as many of you are familiar, can range from attendant care to supported employment and job coaching services to transportation to a wide variety of other things. And our interest in the topic of Medicaid Managed Care has been primarily driven through the fact that whereas in previous decades managed care was a model that, as many of you have already heard, was utilized primarily for the non-disabled, healthy, low-income adult population and limited mainly to acute care services. As of late, we are seeing, because of state fiscal pressures, the expansion of managed care payment systems to people with disabilities and seniors as well, including through the provision of managed care, including through utilizing managed care with respect to long-term services and supports. And from our perspective, there are a number of crucial distinctions with respect to managed care in an acute care context and managed care within the context of long-term services and supports. First, with respect to acute care, managed care contracts are designed to realize cost savings primarily, although not exclusively, through the use of enhanced care coordination. There's better preventative care. People are able to avoid preventable illnesses and, as a result, interactions with healthcare providers, and cost savings realized. But within the context of managed long-term services and supports, people with disabilities are going to be realizing costs even if everything goes perfectly right. Even if services are being delivered in the most coordinated fashion, in the most effective fashion, and people don't realize any preventable illnesses, people are still going to require attendant care, people are still going to require job coaching if that's a service they're utilizing, and writ large, instead of seeing savings emerge through avoiding preventable health conditions, although that creates an element of cost savings in managed care for long-term services and supports, we see a great deal of the cost savings in managed long-term services and support systems emerge because of systems change efforts, predominantly through moving away from legacy infrastructure in the LTSS world, such as institutions, sheltered workshops, and other forms of service provision that we've recognized are both not the best way of delivering quality service provision and also are not the best way of delivering more cost-effective service provision. Now, as of 2014, we anticipate that 26 states are expected to have managed long-term services and supports programs in place. Just 3 weeks ago, the Centers on Medicare and Medicaid Services issued a comprehensive series of technical assistance papers looking specifically at the issue of designing managed long-term services and support systems and what some of the challenges that emerge within that are. You've already heard about discussions with respect to the dual eligible demonstrations. And from our perspective, we want, and in the reports that we've produced, we've aimed to provide state-level advocates and state legislators with tools that can help facilitate stakeholder involvement and have an understanding of the program design that can make long-term services and supports within a managed care process, a managed care structure, something that will improve quality rather than reduce it, which is a significant concern to many advocates. I want to go through a couple of challenges and priorities for managed long-term services and support systems, and then I'll take questions. I'm going to try and leave the majority of time for questions if possible. First, within the context of our discussion, we felt that MLTSS systems should be utilized to advance existing community integration efforts and efforts to shift away from institutional care and towards home and community-based services. One of the ways that this can be done, and one of the ways in which we can prevent managed care from doing the opposite and leading to the expansion of institutional services, is through avoiding carving out institutional care. A number of states that were early adopters of managed long-term services and supports either did or attempted to move the home and community-based service system into managed care while carving out the institutions within their state in fee-for-service, which created terrible incentives to the managed care organizations. It basically meant that if a person with a disability was costing too much, there was an incentive to move that person into an institution, because then it would just be traditional Medicaid's problem, and that person would no longer be within the managed care organization's risk pool. We've been quite adamant that our interpretation of the Supreme Court's 1999 Olmstead decision should rule this out, and in CMS's recent technical assistance document, they've specifically clarified that long-term care options should be, that specific aspects of a long-term care continuum or long-term services and supports continuum should not be carved out. That's different from carving out a population that isn't ready to go into managed care. But if you're putting a population in, you shouldn't say that the community services delivered to that population should be in managed care, whereas the institutional services should remain in fee-for-service. It creates bad incentives. We've also spoken within our reports on the importance of rate setting that incentivizes community living within the capitated rate structure for the managed care organization. And that means that we need to define what we mean by community integration. Some people, when talking about deinstitutionalization, community integration, think it's just a question of shifting people from nursing homes and intermediate care facilities and IMDs onto the home and community-based service waiver. But even within the scope of home and community-based services, there's a tremendous degree of variation in service quality that, if not measured and incorporated into the structure of accountability that the MCOs are being held to, we run the risk of substantial backsliding. State managed care contracts need to include information as to the state's expectation, for example, as to whether or not people will have the right to choose where they live and with how many roommates. If your state has made a priority for its developmental disability service provision system to not place people in residences with more than 3 other people in them, then that needs to be incorporated within the managed care contract, lest the MCO decide that it's more cost-effective to serve people in 6-person group homes than it is to serve people in residences of 4 people or in people's own apartments or in other types of settings. And we also need to ensure, particularly given that many of the MCOs that are entering the field and bidding on these RFPs are not familiar with the delivery of long-term services and supports, that there's not a medicalization of services, and that a medical paradigm that might have worked within the context of acute care isn't taken into the long-term services and supports world, with the result of people no longer having access to the ability to self-direct service provision, to hire and fire their own providers, and to engage in a process of person-centered planning. As many of you have probably heard from advocates in your states, people with disabilities generally don't view the services that help us get out of bed in the morning or succeed on a job or engage in any number of other activities as medical in nature. Now, because of the way our financing system works, they're funded through Medicaid, a health insurance program. But from a practical perspective, If someone has an attendant to help them put on clothes in the morning, or a job coach to help them succeed in a place of employment, or a respite care provider, you don't want that person to be approaching their work in the same way and being subject to the same billing infrastructure as a traditional provider, such as a clinician or a registered nurse within an acute care context. Additionally, the topic of the provider networks available under managed care is one that we have some significant concerns regarding with respect to states that are transitioning from fee-for-service to managed care. Within many parts of the disability service provision system, there's a disproportionate reliance on small providers. And sometimes that can be a good thing. There's a history of innovative techniques in supported employment, in day services, and in residential services, particularly for the intellectual and developmental disability population, coming from smaller providers. But small providers are the most at risk within the context of a transition to managed care. From the provider's perspective, you're suddenly going from a situation in which you had one entity to interact with, the state, with a relatively standard rate structure, to having multiple MCOs to interact with, each of which you may need to, depending on your state's managed care framework, negotiate your own rates with, each of which may have different billing structures, and all of which will be working to shift risk onto the provider rather than onto the MCO or onto the state. The flip side of this is at the same time, the managed care organizations that are entering into your state might not have familiarity with how long-term services and supports providers work or the values framework that's developed within these systems. And so many states that have tried to do this properly, and CMS has a 12-page technical assistance document that looks specifically at the question of managing provider network transitions in managed care, have tried to facilitate prior to the enrollment period in managed care opportunities for providers to interact with the MCO, to have practice billing sessions. Some have put in place requirements on MCOs to have a standard billing infrastructure so that small provider agencies don't have to significantly increase their paperwork burden. Other states have put in place continuity of care requirements within their managed care contracts that ensure that beneficiaries that want to stay with their provider have the ability to do so over the long term. This is particularly important in long-term services and supports because there's often such significant distinctions in quality from one provider to another, not all of which are adequately assessed within the context of state quality management systems. Again, if you're talking about someone who is assisting you often with very intimate activities of daily living, you don't suddenly want a managed care organization to step in and say, well, we've decided it's more cost effective to move you from the person you've been receiving services from in the past to consolidated service provider that we've contracted for your population. So some degree of service continuity, particularly if beneficiaries are happy with the services they're receiving, can be very important. We have a saying in Washington, you probably have it out in the States too, in God we trust, everyone else please bring data. And there are very few areas of policy in which this is more important than with respect to managed care. When done well, managed care can improve quality and reduce costs. When done poorly, managed care can reduce quality and increase costs. But how do we know? Well, we measure. And it's particularly important to recognize that because managed care's history has been within acute care contexts, we've got a very extensive series of measures relating to interactions with a hospital emergency room, interactions with a primary care physician, interactions with specialty care physicians, but less of a tradition of tracking other kinds of outcomes more associated with long-term services and supports. it's comparatively easy to track the number of people with disabilities who are placed in nursing homes or institutions, and to use that as an accountability measure for a managed care organization. It's obviously something that should be done, and it's very important. But once again, within the scope of non-institutional settings, there are a wide variety of different kinds of outcomes. Some states and some quality management systems have chosen to measure everything from whether or not people report that they have a choice as to what they do during the day, which can be particularly important for habilitative services providers within the developmental disability sphere, to people's weekly earnings if the services they're receiving are relating to employment supports. A best practice model we feel quite strongly about is the National Core Indicators Project, which is a joint collaboration between the National Association of State Developmental Disability Services Directors and the Human Services Research Institute. And it includes a wide variety of quality metrics that look beyond simply clinical outcomes and look at questions relating to choice, control, and a number of other factors that are very important in the lives of people with disabilities, but are often not things that state Medicaid agencies have a great deal of familiarity with within the context of their systems. One additional thing to keep in mind: in many of your states, a state Medicaid agency will be, or a governor's office, will be driving the transition to managed care. However, most of the expertise that exists about people with disabilities within your state will be existing within the operating division for a particular population. So New Jersey, for example, where I grew up, has a state Medicaid agency. It also has a division on developmental disabilities. Just because a developmental disabilities agency or an aging and disability agency exists nominally under the control of a state Medicaid agency doesn't necessarily mean that the folks in the state Medicaid agency managing the transition to managed care are talking to the folks with population-specific expertise within these operating divisions. And that's an issue that has profound implications because, again, for the disability community, there are vastly different needs from different populations. And you could have a managed care framework that's designed to work very well for the elderly, but not so well for, say, a 30-something-year-old wheelchair user or transitioning youth with Down syndrome. There's a need to specifically incorporate an understanding of each of these populations and have outcome measures and data tracking that looks at things that are relevant to all of them. Increasingly, state Medicaid programs are playing a role in financing employment services for people with disabilities. CMS recognized this in September of 2011 with an informational bulletin outlining core service definitions for supported employment services and other related employment services financed through a Medicaid system. And we're starting to see significant changes in how these employment services are being provided to people with disabilities. There's a movement that may be present in many of your states called Employment First. The idea behind Employment First is that for each person with a disability entering the service system, as well as for those who are being evaluated after having been in the service provision system for a long time, the outcome of preference is integrated employment rather than a sheltered workshop or rather than a day habilitation center. This is largely emerging from a values framework. We believe people with disabilities should have the right to participate in the workforce, that people with disabilities have better lives when they have the chance to work and to receive pay at or above the minimum wage, and to do so within integrated settings. Over enough time, it's also cost effective to do this because the cost trend for supported employment, which is employment services delivered within integrated settings, trends downward over 8 to 10-year periods, whereas the cost trend for sheltered workshops holds constant or trends upward. Unfortunately, the average managed care contract is 3 to 5 years. And so the cost savings associated with supported employment might be very significant to your state, but might not necessarily be very significant to the managed care organization, which is charged with managing long-term services and supports delivery. This isn't just the case in employment, it's also the case with family support services and a variety of other services that substantially impact people's quality of life and eventually substantially impact cost, but might not do so right away. So there are a few ways you can address that. You can write into the contract that any eligible population should have the right to pick to receive supported employment services or family support services or other services that are not immediately cost effective to the MCO, but will in due time be so for the state and be positive for the beneficiary. You can find ways of tracking integrated employment outcomes within the quality measures that you've incorporated within the managed care contract. And you can also find ways of making this data available not just to the state, but also to the public. Oregon, on its, the website of its State Developmental Disability Service Provision Agency, not only lets any visitor to that website know what percentage of people with developmental disabilities are receiving integrated employment services, and what percentage are in sheltered workshops or rehabilitation settings. It also lets you look at what percentage are receiving all of the above within a specific county or among clients of a specific provider. And so having that ability to track data can be very important for a state agency. It can also be very important for the advocates that are working to encourage systems change within your state Medicaid system. And finally, we recommend that because employment tends to involve more interaction, more service systems than just Medicaid, that the managed care contract specifically outline how an MCO is going to be charged with interacting with the public school system for transitioning youth and the state vocational rehabilitation system. I think we've got 2 more slides. I think we've talked about pretty much everything in here. Again, we're not just talking about traditional health services. We're talking about something that's far broader. And I think I would just end here with a really, well, 2 more slides. I think I would just add here that we need to recognize that even within the context of managed care, these are still state programs. And so just because a state is contracting the delivery of long-term services and supports to a managed care organization does not mean that that state does not need to maintain the policy expertise and the staff capacity within the operating divisions of state government that deal with specific populations of people with disabilities to A, ensure that the MCO is doing what it said it was going to do, B, monitor the outcome measures that ensure the same, and C, have an opportunity to oversee the due process and grievances and appeals procedures that can help address any problems that individual beneficiaries might be having. And then finally, I would just add that again, we need to recognize that different populations of people with disabilities are going to have different needs. Managed care has been done and done reasonably well, depending on what part of the country you're in, for every population of people with disabilities, including the intellectual and developmental disability community, which is probably the hardest population to do it in. Having said that, each population has to be assessed differently, and your state needs to look at the provider networks that you have available, the degree of stakeholder engagement, and the degree of competency of the managed care organizations you've selected for each of the major populations. Developmental disability, mental health, physical disability, aging, the realities, priorities, and outcomes and ways of measuring all of the above for each of these populations are radically different. And many states should and have made different decisions about when and how to move to managed care with each of these populations. I think that should leave us 20 minutes for questions, so right on time.